industries in the world demand as much scrutiny and regulation as pharmaceuticals. In medicine, quality is non-negotiable.
The World Health Organization.
Since 1948, the United Nations body, the World Health Organization, has been the foremost authority on pharmaceutical standards around the globe. Only companies who successfully pass their rigorous inspection process are awarded the World Health Organization pre-qualification standard. This seal of approval ensures customers that a brand of medicine meets the strictest safety and quality control standards in the world. Of 900 pharmaceutical companies, Getz Pharma is the only organization to have received this certification. Our facilities are equipped with state-of-the-art machinery explicitly designed to prevent cross-contamination by using continuous environmental monitoring. All our raw materials are procured solely from WHO or US FDA-validated suppliers and are carefully audited before they are declared compliant. Our quality control laboratories and product testing departments remain at the forefront of our manufacturing process. A series of stability testing procedures allow us to guarantee that our medicines maintain their quality long after they've been delivered to pharmacy shelves. We have taken great care to simulate environmental conditions to ensure that medicines retain their efficacy and longevity in our particular climate. In accordance with WHO guidelines, our employees are highly qualified and regularly receive training in Europe and Japan, keeping us at the cutting edge of rapid advances in pharmaceutical research. Our quality guarantee makes us the only pharmaceutical company which can sell medicine to global bodies such as UNICEF and that are approved for sale by international markets. Today, Getz Pharma is the single largest exporter of pharmaceutical products. But more importantly, our WHO certification means that doctors and patients have access to the best quality medicines in the world at affordable prices. At Getz Pharma, we are proud of this achievement. We believe that our people deserve the same access to quality medicines and medical care the world over. Because where you live should not decide if you live.
Good evening to you all. On behalf of Getz Pharma, I would like to warmly welcome all of you for today's webinar. Our speaker for today's webinar is Dr. Maheshaka Wijayawardena, Consultant Pediatrician attached to Based Hospital, Wathupitiwala. Dr. Maheshaka Wijayawardena is having MBBS, Faculty of Medicine, University of Colombo, 2003, Postgraduate Doctor of Medicine in Pediatrics, MD, 2011, August, Postgraduate Institute of Medicine, University of Colombo, Diploma in Child Health, DCH, 2007, December, Postgraduate Institute of Medicine, University of Colombo. And Dr. Maheshaka is a member of Royal College of Pediatrics and Child Health, MRCP, CH, October 2014, Royal College of Pediatrics and Child Health, London. And Dr. Maheshaka has undergone training, 2-year training from 2013 to 2014 at Darlington Memorial Hospital, UK. And also, Dr. Maheshaka has worked as a consultant pediatrician at AMH Hospital, Kalmunai, General Hospital, Ampara for 4.5 years. And currently, Dr. Maheshaka is working as a consultant pediatrician last 4 months, Based Hospital, Wathupitiwala. Sir, it's a great honor to have you here as a speaker for today's webinar. Dear participants, if you have any queries, you can post on Q&A section or chat area. Sir, over to you to conduct today's webinar.
Okay, thank you, Dishan, for that kind introduction. I'm going to discuss today about urinary tract infections in children. I hope most of you have seen and managed children with UTIs. And I just want you to think like whether you have managed these children in a correct way. For example, have you taken culture before starting antibiotics, and have you treated them for an appropriate duration with appropriate antibiotics, and have you referred them, or have you arranged the necessary investigations for them? Did you have any idea about the possible consequences if you did not treat them properly? Right. So we'll talk about this as we go on. So we are going to start with a small case history. So this child I have managed a few years back when I was a senior registrar. This 1-year-old baby was seen at cardiology clinic for a follow-up echo. So at the cardiology clinic, they usually check the blood pressure routinely before doing the echo. At that time, they found that this baby is having high blood pressure. As a result, they referred this child to us, pediatricians. So we have done further investigations to see this child was having chronic renal failure. When we look back into the past history of this child, we found out that this child was treated for sepsis during the neonatal period and also ventilated for a couple of days. And at that time, they have done a 2D echo, which showed left ventricular hypertrophy. So that's why they came for the follow-up echo at 1 year of age. So we can assume from this story or the case history that this child most probably had a UTI at the time, like perinatal period, during the perinatal period, and then as a complication got hypertension, which went on undetected. And by the time we saw that child, he was in established chronic renal failure. So if we have detected this child's problem, I mean blood pressure, initially, we could have managed it properly and prevent this child going into chronic renal failure. So I hope this case history helps you to understand the importance of managing these UTIs properly and adequately. So this unfortunate child, couple of years later, died due to the complications of chronic renal failure. Right. So I'm going to if you have any questions during the presentation, you can use this chat box or Q&A to direct them to us. And before that, I would like to ask you questions from you all. So what I want you to do is you get a piece of paper and quickly write down answers to these questions, or you can type in the chat box the answers. So first question is, what is the commonest organism causing UTIs in children? And then what is a significant growth in urine culture? And how do UTI present in children and neonates? What is bowel and bladder dysfunction? And how do you examine a child with possible UTI? And how do you investigate and treat UTI? What will happen if you don't treat them properly? So quickly, within one to 2 minutes, quickly write down the answers or type in the chat box. So we'll start with the first question. What is the commonest organism causing UTI? So I think most of you all have answered correctly. So it is caused by a bacteria called E. coli. So say you were given a chance to get a UTI. So you have a choice to get the UTI from E. coli and from an non-E. coli bacteria. So which one do you prefer? So studies have shown, like if you get a UTI from a non-E. coli bacteria, these children are more likely to get renal damage and renal scarring and complications. So in that sense, it's better to get a UTI from E. coli, right? So you will find the answers for these questions during my lecture, but just I want to keep you awake and do a bit of brainstorming. So what is the significant growth in urine culture? Right. So most of you have answered more than 10 to power 5. So, right. So why do we take as 10 to power 5, more than 10 to power 5, not 10, more than 10 to power 7 or 10 to power 9. So to tell you about the history behind it, so in some time back in 1959, a person called Cass, for laboratory convenience, he has taken the cutoff for this significant growth as 10 to power 5. So it's not based on any scientific research. So later on, when they did research, and they found out that in a true UTI, there will be around 10 to 7 up to 10 to power 9 amount of organisms. So in that sense, so if you take 10 to power 5 as the positive culture report, you'll be overdiagnosing UTIs by around 50%. So most of these UTIs we see with like when you get a report from the lab with saying more than 10 to power 5, it may be a true UTI with 10 to power 7 to 10 to power 9 amount of organisms, or it can just be a contamination with 10 to power 5. Remember that. So then how do UTI present in children and neonates? So children, UTI, like children, you can again divide them. The smaller children, maybe less than 2 years, who are not verbal. So that sort of the babies, they will present with, they can cry while passing urine. They can have periodic episodes of fever without any focus. And so they can have bedwetting, or especially if it is a newly onset bedwetting. And compared to that, all the children, they who are verbal, they will tell that there's discomfort when passing urine. And they can also have high fever, which is anrhygos, which is suggestive of upper tract UTI. And neonates, they are different actually. So they present in different ways. Those who work in NICUs or run well baby clinics, you might have seen these newborn babies present with problems like fever. They can come with fever and failure to thrive, not gaining weight properly. And some will come with prolonged jaundice, prolonged obstructive jaundice. And they can also have other signs of sepsis like apnea and so on. So they are different. So if you investigate a child or neonate with poor weight gain in your clinic, then you have to do a urine culture to exclude the UTI. So that is one investigation we do. So what is bowel and bladder dysfunction? So this term may be new to some of you. Tell you in brief, like bowel dysfunction is like children with constipation. So they are more prone to get UTIs. On the other hand, bladder dysfunction is, for example, children like school-age children, when they go to school, like they are reluctant to use the common toilet. So what they do is they drink less amount of fluids, and then they withhold urine, and they will not go to the toilet. So that sort of a behavior can predispose to urinary tract infections. And how do you examine a child with possible UTI? So what are the things you examine in a child suspected of having UTI? Any child, we have to check the growth parameters, whether the child's growth is appropriate for the age. And then we have to check the blood pressure, as the case history I discussed earlier. So we have to check the blood pressure. And then other abdominal examination. For example, you can look for abdominal masses, suprapubic tenderness, and renal angle tenderness. And also you have to have a look at the back to spinal deformities. And you can also have a look at the lower limb neurology. Right. So how do you investigate and treat UTI? So in our setting, there are a number of investigations which are available to treat, investigate these children. They include ultrasound scan, KUB, kidney ureter bladder, and then MCUG and DMSA. and then DTPA scan if there's obstruction, usually done by surgeons, and MAC3 scans. There's a difference, like in our setting, actually in Sri Lanka, when we treat, investigate a child for a UTI, all children should undergo at least ultrasound scan of kidney, ureter, bladder. So it is a must, right? Why is that? So in UK they don't do that. So if you see the so I'll come to that later. So if you see the NICE guidelines, they don't recommend all the children with UTI they should undergo ultrasound scan. Why is that? Because in UK these babies, actually when they are in utero, these mothers will undergo a detailed CR scan, all of them. So most, like if there's any renal pathology, they will write it down, and usually they write a plan of action after delivery. So they say this child is having hydronephrosis of this amount and this much, and then after delivery you have to have another ultrasound scan, KUB, postnatal scan, and then start on prophylaxis and refer to the nephrologist. Like that, they will put a plan during the antenatal period itself. But in our setting, it's different. Not all the children, all the mothers undergo CR scans to look for renal anomalies. So as a result, we recommend all children with the UTI, they should undergo at least ultrasound scan, KUB. And treatment of UTI, we'll discuss about that later. And what will happen if you don't treat them properly? So as I mentioned earlier, so if you don't treat properly, so the kidneys of children, kidneys grow until around 4 to 5 years of age. So as a result, like we get a scar, like if we have a wound in the skin, we get a scar there when it is healing. So like that, if there's a UTI, the kidneys will also develop these small scars. And if it's recurrent, there will be more scars, and the risk is higher until around 4 to 5 years of age. So as a result, if you don't treat them properly, and especially if you delay the treatment, if you don't treat them properly, duration or adequate antibiotics if you are not used, so then these children can have complications like hypertension, proteinuria, and eventually end-stage renal disease. So with those questions, then we'll move on to my proper lecture. So I'm going to talk about epidemiology and risk factors, and then clinical features and diagnosis, UTI in neonates, acute infectious cystitis, acute management, imaging and prognosis, and long-term management and prevention. So epidemiology and risk factors. As you know, UTI is a common and important clinical problem, and you can actually divide the UTIs as upper tract UTI and lower tract UTI. So upper in the sense like infection affecting the kidney or pyelonephritis, which is like more likely to cause renal damage. Lower UTIs are cystitis, right? And which is less severe. But again, having said that, on clinical grounds, it is very difficult to differentiate the two. So epidemiology, so we have to have some understanding about the prevalence of UTI to estimate the probability of infection in a particular patient. And also the presence of risk factors for UTI and renal scarring will help you to guide your investigations. So overall prevalence of UTI is approximately 7% in febrile infants and young children. But it is affected by various other factors like age, race and ethnicity, sex, and circumcision. So prevalence is highest among uncircumcised boys and particularly younger boys less than 3 months of age. And white children have 2 to 4-fold higher prevalence of UTI than black children. And again, girls have a higher prevalence, 2 to 4-fold higher prevalence than do circumcised boys. And white girls with high temperature have a prevalence of up to 16%. So microbiology. So as I mentioned earlier, E. coli is the most common bacterial cause for UTI. So it accounts for approximately around 80 to 85 percent of UTIs in children. So other organisms like other gram-negative bacterial pathogens can also cause UTI. For example, Klebsiella, Proteus, Enterobacter, and Citrobacter. And other gram-positive bacterial pathogens, for example, Staphylococcus saprophyticus, especially sexually active girls. These organisms can cause UTI. Then other enterococci and Realis Staph aureus in preterm neonates. So as I mentioned earlier, infection with organisms other than E. coli is associated with high. So how do these organisms? These organisms ascend to the kidney. So as you know, these organisms originate in the GI tract and then ascend into the kidneys, and then they cause strong inflammatory response. So as a result, you get kidney damage. So the viruses and fungi are the uncommon causes for UTI in children. Viruses include adenovirus, enteroviruses, and so on. And fungi are mentioned there. So viral UTIs are usually limited to the lower urinary tract. So how do these children present? So sometimes you may have seen these children, like they come with gross hematuria, short lasting, and this lasts for only for a few hours. So in the morning, child might have red color urine, but by evening, it will disappear. But when a child comes like that, picture like that, so you have to find out where this blood originate from. So as you know, it can originate from anywhere in the renal tract. It can be due to a systemic problem, like for example, if the child is having DIC or having a very low platelet count, it can cause blood stained urine, or it can be due to a problem in the kidney, like renal stones, calculi, or renal growths. So then it can be due to a problem in the ureters also. It can be due to a growth in the ureters, or it can be due to a stone getting stuck in ureters. Or then most commonly it is due to the viral infection of the bladder called cystitis. We call it hemorrhagic cystitis. And then it can also be caused by problems in the urethritis. So there are ways of detecting where these red cells are originating from. So if you do a microscopy, if it is originating from the kidneys, you might see casts, red cell casts. And so you can also check urine for dysmorphic red cells. If they are coming from upper tract, you will see these dysmorphic red cells. So risk factors for fungal UTIs include immunosuppression and long-term use of broad-spectrum antibiotic therapy, and then indwelling urinary catheters. So immunosuppression you may see in children who are on treatment for various cancers, or children who are on steroids for nephrotic syndrome, or other children with syndromic children with immune problem. So what about pathogenesis? So as I mentioned earlier, most of these organisms originate from the GI tract. But in neonates, it can be due to bloodborne infection. Initially, these pathogens will colonize in the periurethral area, then they will ascend. And some bacteria have special mechanisms to attach, like E. coli, for example, they have a virulence factor called pili. So these pili help them to ascend into the upper tract. Even they can ascend even without any abnormality in the urinary tract, or like so what are the host factors? So prevalence of UTI, as I mentioned earlier, is highest in boys younger than 1 year and girls less than 4 years of age. And lack of circumcision. So uncircumcised males have a higher prevalence, like up to 4 to 8-fold higher prevalence than circumcised male infants. Actually, despite that increased risk, most uncircumcised boys do not develop UTI. And research have shown like to prevent one UTI, you have to do circumcision in 111 patients. So it is not routinely recommended to do circumcision in the aim of female infants again have 2 to 4-fold prevalence of UTI than male infants. And we assume it's due to the females having a short urethra, but there are other contributory factors as well. What about race and ethnicity? So white children have a higher prevalence compared to black children. Genetic factors also contribute, and first degree relatives of children with UTI are more likely to have UTI than individuals without such a history. This may be consistent with the fact that children with VUR, it is usually familial. So if you find one child in the family is having vesiculated reflux, you have to screen the other children in the family for VUR. And this adherence of bacteria may be genetically determined. And what about urinary obstruction? So children with obstructive abnormalities in the genitourinary tract are more prone to get UTI. Why? It is because the stagnant urine is a good culture medium for the uropathogens. So what are these predisposing obstructive abnormalities? They include anatomic conditions like PU valves, posterior urethral valves, or uretropelvic junction obstruction. So posterior urethral valves are very important to exclude in male babies or infants, right? So you have to ask, like every mother with a male child, you have to ask about the urinary stream. So if the mother says there's a good urine stream, they are unlikely to have a posterior urethral valve. So as you know, this valve is in the situated in the posterior part of the urethra, and as a result, they will have a poor urinary stream. So sometimes ultrasound scan might show changes suggestive of PU valve or bladder features of bladder outlet obstruction. But the definitive test is MCUG, which will show a characteristic appearance. And neurologic conditions like meningomyelocele with neurogenic bladder can predispose to UTIs. For example, children with meningomyelocele, they will have a neurogenic bladder, and as a result, there's even after passing urine, these children will have a residual volume in their bladder. So if you do a contrast study in the bladder, you will see what you call a Christmas tree appearance in this bladder, trabeculated bladder wall. And some of these children, like we recommend bigger children can do that themselves, but others, we advise mother to do frequent catheterization to get rid of that urine which is left in the bladder. And other functional conditions like bladder and bowel dysfunction can also give rise to stagnant urine. So a few words about bowel and bladder dysfunction. It's an abnormal elimination pattern. It can be in the form of frequent or infrequent voids, daytime wetting, urgency, and infrequent stools. So we talked about this bladder and bowel incontinence earlier, and withholding maneuvers, I mentioned that earlier. The pathophysiology behind this is varied, but it includes behavioral abnormalities of the function of the muscles of the pelvis, bladder, and the sphincter. And bladder and bowel dysfunction is like actually often overlooked actually. And bladder and give rise to persistent vesiculated reflux and renal scarring and even recurrent urinary tract infection. So what is vesiculated reflux? It's the retrograde passage of urine from the bladder into the upper urinary tract. And it is the most common urologic abnormality in children. And as I mentioned earlier, it can be familial. Sexual activity, especially in girls, can also predispose to urinary tract infections. So this is the grading of vesiculated reflux. So lower grade ones usually are unlikely to cause renal damage, but higher grade ones, grade 4 and 5, and higher grade ones may need surgical interventions. But research has shown even this higher grade VUR will resolve to some extent with time. Again, bladder catheterization, the risk of UTI increases with the bladder catheterization and depending on the duration as well. So you have to make sure when you catheterize a child, make sure you get rid of the catheter as early as possible. And what are the risk factors for renal scarring? So renal scarring is the loss of parenchyma between the calyces and the renal capsule, and it's a complication of UTI. So long-term consequences of renal scarring include decreased renal function, hypertension, proteinuria, and end-stage kidney disease. The diagram there shows DMSA scan. It's a posterior view, and arrows show these scarred areas. As you know, this DMSA will show you a differential renal function, that is as well as renal scar. So what are the general risk factors for scar? Recurrent febrile UTI and delay in the treatment of acute UTI can give rise to renal scarring. Bowel and bladder dysfunction and obstructive malformations we discussed earlier, and VUR. And after first UTI also up to around 15.5% of children can develop renal scarring. And predictors of renal scarring in these children include again VUR, abnormal renal and bladder ultrasound, higher inflammatory markers, high CRP and high neutrophil count in the count, and then high temperature, and if the UTI is caused by organisms other than E. coli. And a few words about clinical features and diagnosis of UTI. So what is a UTI? So it is a significant bacteriuria of a clinically relevant pathogen, and they should also have pyuria. So as I mentioned earlier, fever may be the only sign of UTI, especially in young children. What are the things you examine in a child? So the answer to one of my questions earlier is here. So you have to measure their temperature, blood pressure, and growth parameters, and abdominal examination for tenderness or mass, an assessment of suprapubic tenderness, and examination of genitalia in both males and females is very important, right? So, so males, they can have non-retractable prepuce, and which can as a result, the non-retractable prepuce actually there's a small risk of causing UTI, as I mentioned earlier. But when there's a non-retractable prepuce, organisms and shedded cells can accumulate under the foreskin, and there will be colonization of bacteria there. So it's not a true UTI, but the bacterial colonization. And if you do a urine culture in such a child, you might get a positive culture. But if it is causing recurrent balanitis, infection involved in the prepuce, then again you have to get rid of that prepuce, extra prepuce. Yeah. And then girls, you have to have a look at the genitalia to have a look to see whether there's any labial adhesions. Mind you, when you collect urine samples in girls, so most of these girls will pass urine, some amount of urine into the vaginal area, and then when you collect that urine sample, you will see epithelial cells and the pus cells originating from the vaginal area. So to prevent that, you can ask the mother to separate the labia and legs and take another repeat urine sample. And as I mentioned earlier, you have to look at the lower back to look for any spinal dysraphism, tuft of hairs, and so on. And then you might look for other sources of fever, like source for the fever. So what are the lab tests you do in these children? So you can, in our setting, most of the time we do urine culture and urinary pool report microscopy. But we can also do dipstick analysis. So in small children, the best way to collect a urine sample is catheterization or suprapubic aspiration. So in bigger children who are toilet trained, you can do collect a clean voided midstream urine sample. Bags are not recommended anymore. So what is the amount of significant bacteriuria in a child? As I mentioned earlier, we take more than 10 to power 5 colony-forming units as that is a single organism. Mixed organisms, that indicates a contamination. So clean cat specimen more than 10 to power 5. In a catheterized sample, half of that, more than 50,000. And suprapubic aspiration, any amount of organisms taken as positive. So some children can have asymptomatic bacteriuria, and we are not usually treat that. So that may be due to the colonization. And there are other conditions listed there can give rise to any child, by the way, any child with any significant systemic illness will have few white cells. So a few words about urinary tract infections in neonates. So prevalence is around 7 to 15%. UTIs are uncommon in early days, like first 3 days, and generally present in the second week. And again, uncircumcised males, incidence is higher. And it increases, the prevalence increase with decreasing gestational age. So in children, neonates as well, and in children, main thing is like when they get a UTI, we have to exclude the structural abnormality in the genitourinary tract. So that's why we do a scan. So in term neonates with community acquired UTI, it is most of the time caused by E. coli, but hospitalized neonates, preterm neonates, it can be caused by staph and Klebsiella. I discussed about this earlier. So these neonates can present with failure to thrive, febrile episodes, and jaundice, prolonged obstructive jaundice, and vomiting, and rarely with apnea and hypoxia. So the best way to collect the urine sample from a neonate is by suprapubic aspiration or bladder catheterization. Clean void bags are not used anymore. Again, I discussed about this significant growth earlier. So neonates actually, when compared to adults, they are different. Right? So their immune response is not good. So they are more prone to get severe infections, and if you delay the treatment, they can die within few hours. So they can develop septicemia, meningitis, and die in few hours. So it's very important. Like in adults, we don't wait for them, wait for the reports, culture reports to start antibiotics. So if you suspect sepsis, especially, so how do these neonates present? Like, what are the features of sepsis? So unless proven otherwise, if the mother is complaining, child is not sucking well, poor feeding, less activity, fever, and especially if they have risk factors, like if the mother had fever, high fever, chorioamnionitis, prolonged dribbling, and so on. So then we have to have a high degree of suspicion, and we have to start the treatment early. So if relevant, we might do a blood culture and CSF culture as well in these children. In such children, we can use combinations of antibiotics like ampicillin and gentamicin. Later on, when we get the culture reports, we can adjust our treatment. Usually uncomplicated UTI in children, neonates, we treat for 10 to 14 days. And some clinically stable children, we can later on change over to oral antibiotics. So when do you do a MCUG? So if there's an abnormal renal ultrasound, or if the UTI is caused by non-E. coli pathogen, or if there's recurrent UTI, we have to consider doing a MCUG. Words about cystitis. Again, we have to treat with antibiotics, which will cover E. coli. Usually, we use second or third generation cephalosporins to treat them. So if a child is responding to our treatment, so say we are treating this child for UTI with antibiotics, and if our treatment is successful, then they will show a dramatic improvement within 24 to 48 hours. So what happens if they don't respond? Like if the child is better, or if the high fever spikes are going on. So in that situation, we have to think about possible complications like abscess formation or retroperitoneal collections, right? So then it's a indication to do there's indication to do a urgent ultrasound scan on that child. So a few words about acute management, imaging, and prognosis. So most of these children can be managed on outpatient basis, but there are indications for hospitalization like age less than 2 months, clinical urosepsis like if they are septic, immunocompromised patients, and if they can't tolerate oral antibiotics, and if there's lack of outpatient follow-up, and if there's failure to respond to outpatient therapy. So we have to take a urine culture, then start on appropriate antibiotics, and we can be guided by the local resistant pattern. These antibiotics should cover. And if they are like once we get the definitive reports, if appropriate, we can change our management. So children who are highly likely to develop renal involvement, recommendation is second generation or third generation cephalosporin. And if you are going for IV antibiotics, you can use cephalosporins or aminoglycosides. Duration depends on the age of the child and the clinical scenario. Usually, febrile children are treated for up to 10 days. And then afebrile children can be treated for shorter duration. Then when to do MCUG, any child with more than two febrile UTIs and child with first febrile UTI, and if there's any abnormality in the ultrasound scan, or if there's a combination of high temperature and any pathogen other than E. coli, and if there's a poor growth or hypertension. So majority of children will not have long-term sequelae, and it's very difficult to predict the long-term sequelae. So diagram this MCUG shows dilated posterior urethra in a child with the posterior urethral valve. So various guidelines various guidelines are there to manage these children with UTI. And they differ. So, for example, if you take NICE guidelines, they recommend to do an ultrasound scan if the baby is less than 6 months of age. And if the baby is more than 6 months, only do a scan if there's an atypical or recurrent UTI. And then less than 6 months, no MCUG unless there's atypical UTI or recurrent UTI or positive ultrasound scan. More than 6 months, they don't recommend MCUG. And DMSA in a child less than 6 months if there's atypical or recurrent UTI. Again, all the children older than 6 months, again, you have to do a DMSA if atypical or recurrent UTI. So other guidelines I have mentioned there, you can go through that. So what is this atypical UTI? So characteristics include septicemia, poor urine flow, abdominal low bladder mass, raised renal functions, failure to respond to antibiotics within 48 hours, and non-E. coli pathogen. Long-term management and prevention is very important to educate the parents. Like say if you have treated this child for a UTI and now child is going home. So you have to tell the mother, if you are going to a doctor next time when you get a fever, you have to think about a UTI if there's no obvious focus for the fever. So then in that case, you have to better to take a urine culture if you are going to start them on antibiotics. So children with bladder and bowel dysfunction, you can use double voiding, and then you can use laxatives, and if appropriate, you can do a referral to a subspecialty. And sometime back, we used to do a post-treatment urine culture to see whether the child had got rid of the organism. But nowadays, you don't do that routinely, right? So if you treat it, you treat the UTI for the appropriate duration, and if the child is well, you should not do another urine culture to check whether the organisms are still there. So if any child is having recurrent UTIs, you have to start them on antibiotics. So also, if there are severe, like children with severe initial episode of UTI, and if there are additional risk factors, you can consider starting prophylaxis. Usually, once you start them, you have to continue them for 6 months, then you have to review. So during that 6 months period, if there are no breakthrough infections, you can think of stopping. In the meantime, if they get recurrent infections during that time, you have to continue. So that concludes my presentation. In a summary, typical UTI needs minimal imaging without long-term follow-up. The current emphasis is on rapid institution of treatment and not on extensive investigations. And atypical and recurrent UTIs need MCUG and DMSA plus or minus prophylaxis. Neonates may need blood and CSF culture if they are ill or having high fever. Children with renal scars and urinary tract abnormalities need long-term follow-up. Thank you. We'll try to answer a few questions if time. So this question, what are the indications to perform ultrasound scan in the PED UTI? So as I mentioned earlier, in our setting, all the children with the first episode of UTI, you have to do at least ultrasound scan of the kidney, ureter, and bladder. And when you do this, like if it's a afebrile and simple UTI, you can do it on elective basis. But if it is like if the child is having high fever spikes and if the child is not improving, in that situation, we have to think about complications like renal abscess and retroperitoneal collections of pus. So in that case, we have to do ultrasound scan while the child is involved. Can we have the presentation? Of course, I'll arrange that. So there's another question. How can you interpret UFR and culture if child has been pre-treated with antibiotics? So in this situation, so it's not a very uncommon situation. Most of the time, these children, we get to the ward and to the clinics, pediatric clinics. They were treated in the private sector with antibiotics, but without taking a culture. So in that situation, even like once you start treatment, if you take another culture, it will come as negative. So so that is a difficult situation actually. But you can have a look at the UFR. If it is strongly positive, still you can treat them as UTI, but the culture will come as negative. So on clinical grounds, you can decide to do a ultrasound scan KUB and decide on further management. But again, having said that, if that child was started on not started on proper antibiotics, then you will get a positive culture. Like for example, you are not started on that particular correct antibiotic, so culture can still come as positive. So how to manage tight prepuce and local pus, right? So tight prepuce actually in our like community, we don't do routine circumcision. So most these young children, they have an unretractable prepuce. So usually this prepuce become retractable after around 8-10 years. So what we usually do is we prescribe hydrocortisone cream to apply in the prepuce and ask the parents, mothers to retract it as far as possible. And when they clean also, they can apply some soap and pull that foreskin back. So most of these children will get rid of that problem once they are 8 to 10 years old. But if it is causing balanitis, especially one episode you can just treat and see. But if it is recurrent, then it's an indication to do a circumcision. So urine dipstick actually we have used some time back. So there's a question: what is the place for urine dipstick to diagnose UTI? So there are strips in our setting. We don't usually use sticks because we don't have have that facility. But in UK we have used it, and it will show these nitrites and leukocyte esterase, and then we can guide our, like, if they are positive, then we can say there's a high chance of them having UTI. So there's another question. Can you answer one more question? Yes. Yeah. So how to treat labial adhesions? Most of the time, what we do, I tell the mothers, is to keep that genital area clean, and then Primarine cream. We advise them to apply Primarine cream just using the finger in that and over that labial adhesion. But if it doesn't resolve with that estrogen therapy, then we can refer them to a surgeon, pediatric surgeon or a general surgeon. It's not a complicated surgery. What they do is they will anesthetize and separate the labia. So criteria to start prophylaxis I have mentioned earlier. So earlier, we started some guidelines recommend less than 1 year children, you have to start them on prophylaxis. But now we start them, as I mentioned earlier, if they are atypical UTIs or recurrent UTIs, and then continue it for 6 months. And usually during that time we arrange the investigations. If they are okay, and if they don't have any more UTIs during that time, we can stop them. And mind you, male infants, because they are more likely to have structural abnormalities like postureuteral valves, we tend to investigate more compared to girls. And first line prophylaxis, nowadays we use you can use cephalexin and nitrofurantoin. As you know, nalidixic acid can cause benign intracranial hypertension. Even nitrofurantoin can cause benign intracranial hypertension, and the main problem is the taste. Cotrim we don't use these days because it causes a lot of allergies and other problems, mainly allergy. Is neurogenic bladder itself is an indication for prophylaxis? So yes, most of these children, we treat them with these children are managed by us as well as it's a shared management with the GU surgeons and pediatric surgeons. So most of these children are on prophylaxis because they are more prone to get, they have stagnant urine there, and then especially if they are doing frequent catheterization by themselves, or if the parents are doing catheterization. I have seen children with a lot of complications, like sometimes they have very turbid urine and they have positive cultures with unusual organisms. So it's advisable to keep them on prophylaxis. So why can't we use cephalexin for prophylaxis in older infants? Yeah. So and why do we use nitrofurantoin? Why do you use nitrofurantoin? So sometimes there's a situation like some recommend you should not use cephalexin as prophylaxis because they are more likely to develop resistance. But new guidelines actually they say you can use cephalexin. Other situation is sometimes we get a child with UTI. This child is on prophylaxis and child get a breakthrough UTI. But this UTI, this organism is not sensitive to our the antibiotic we are using as prophylaxis. So actually, that situation you don't have to change the prophylactic antibiotic. You can treat that infection with the sensitive antibiotic, and still you can continue the prophylaxis. Nitrofurantoin, so sometimes we get the nitrofurantoin culture reports, and the only sensitive antibiotics are the IV antibiotics and nitrofurantoin. In that situation, we use nitrofurantoin, and guidelines actually recommend it as a prophylactic antibiotic. Anyway, thank you for the answer, asking a lot of questions. That means you have been awake during the lecture. Thank you very much. I'll stop there then. Thank you very much for your patience.
Sir, thank you for that interesting and insightful presentation. I'm sure it's a value addition for all. Dear participants, thank you very much for your active participation. We will be signing off from today's webinar. Thank you very much.